in this video I will show how we can do an endoscopic carpal tunnel release without much of any other instrumentation. Just what you need is a 4 mm normal knee arthroscope. Here in this you have used, you have drawn the Kaplan's cardinal lines, and you have putting a S-mark bandage, and you put the tourniquet. It's totally under local anesthesia. You are putting an incision at the crease, transverse incision on the wrist crease. The incision doesn't move into the hand. Actually, the hand is totally spared from the incision. So, have a wireless mic, please. So, so as the incision doesn't go at the hand, all the incision is at the carpal crease only. So that's a small incision. You are using the 4 mm arthroscope. You are not using the irrigation fluid or anything. You are just using the scope to put it inside. First, once you put the incision, what you see is the palmaris longus. You just separate it with a retractor. Yeah. Okay. And then you see the retinaculum. This is a flexor retinaculum. You are seeing cut. And you are taking a small scissors which is curved to the ulnar side. That is an ulnar side curvature to the scissors. You are visualizing it directly through the scope and visualizing the flexor retinaculum and slowly cutting it. You can see that in one hand you have the scope, other hand you have the scissors. You are just moving the scope forward and slowly, millimeter by millimeter, take care that you shouldn't open the scissors too much inside the flexor in the tunnel. You can slowly see and progress it towards the end. See that median nerve is down. You are nowhere damaging it. Your both hands are stable on the table. Okay, your both hands, your elbows are kept into the table, and it is absolutely stable. Your hands will not move. With one hand you are seeing the scope, and other hand you are just moving the scissors forward. See that. The entire flexor retinaculum can be slowly released like that, and you can just open the scissors edges so that it will also increase the space there. It's like a neurolysis of the slowly open that, and you can have absolute control of what you are cutting, because you are seeing the entire thing. You are slowly putting the scope inside, and you can do the same thing for the opposite in the forearm region. It's far more simple. You can see that extension of the retinaculum in the forearm region. And once you cut the entire thing, you can see the muscle belly. This is actually not a fast forward thing. It will take only 4 to 5 minutes. That is, this entire video will last almost 3 minutes, and you can put last small sutures, and that will be along the crease. So it will not, this is a usual scar, not that big, but this is a normal when it opens scar, and this is a scar. You can't see the scar at all. This will be hidden in the crease. So there is absolutely a totally scarless surgery. So I have done almost 150 cases from around from 2015. I have published the functional outcome also. So this looks very difficult, but initially in the maybe or the first 10 or 20 cases you might need some time, maybe some 10 or 20 minutes. But now my average time is 8 minutes. And the only thing is that the patient will complain of tourniquet pain because you are doing it totally under local. Initially when my time was 10 or 20 minutes, I had a bit of a problem with it. But since now I finish it fast, so when the patient starts complaining of tourniquet pain, my surgery is over. So this looks, the only thing is that you should take care of the recurrent branch of the median nerve, and you can see it properly because you are putting totally under arthroscopic guidance. So you can see the median nerve properly, you can see it entirely all the way through, and you can release it. So it doesn't need any sort of endoscopic cannulas or endoscopic retrograde knives. No two portals, only single portal is enough. Only thing is that a learning curve is maybe first 10 or 20 cases, it might need time. You can convince them for an open release if you are finding difficulty in it. But still, if you are trying to do converting it into open release, better do not a transverse incision, because it will be difficult to convert into an open one. You can use a longitudinal incision and do the same thing with the scope.